Hello everyone, Namaste. This is Dr. Harshavardhan, urologist from Kakinada. In this video, I want to discuss about the feasibility of supine PCNL in spinal anesthesia in an upper calyceal stone, which is looking like a diverticular stone. This particular patient had bilateral upper calyceal stones. The right stone button has been cleared 1 month back. As you can see in this image, I tried to park the guide wire, but I could not gain access into the pelvic calyceal system. So the guide wire was coiled in the upper calyx around the stone. This is the RGP image. You can see the upper calyx is standing out from the rest of the pelvic calyceal system. So in these kind of situations where the contrast is not reaching, and if you are having a radio opaque stone, you can adhere to the principles of understanding the C-arm if it is anterior or posterior to the desired target, and then you can make a stone guided puncture as I have done here. You can see a large stone around which the guide wire is coiled. So once I have ascertained that everything is cleared, then gently I have removed the guide wire. In this particular patient, I did not dilate to 20 French. It was a mini perk. Dilatation was done only up to 16 French. So the stone burden was slowly lithotripsed and complete stone was cleared. But during the course of surgery, I have noticed that there is a small defect or rent on the medial aspect of the upper calyx. So I was cautious enough to be gentle. So I did not use much pressure because it may further cause damage on the medial aspect. And the tip and technique here is when you are trying to uh, fragment the stone, make sure that you are placing the stone elsewhere so as not to make further injury. So once the complete stone burden has been cleared and complete thorough walk-in into the upper calyx was done, now a reassessment of the uh, defect was done. So I was now confident that the stone is cleared and then can proceed for stent placement. So as I tried to pass the guide wire, it was not going into the pelvic calyceal system, and during the course of my surgery, I could not see the electric catheter also. So my doubts of it being a calyceal diverticulum has strengthened, or it might be a cut-off calyx because of long-standing edema due to the stone. Whatever it is, the concept is same. If you are not able to find out the access into the PCS, you can instill some methylene blue from below. As I was not having a sterile methylene blue, I have injected some amount of betadine. So one more technique and tip is don't try to pass the guide wire directly through the source from where the betadine is being afflexed. Either use a central rod because it will stabilize and it will ease the passage of guide wire. As it is a mini perk, there is no chance of passing a central rod. I used a electric catheter, and with gentle manipulation over the electric catheter and guide wire, I could open up to the open the mouth of the closed or cut off calyx, and I could enter into the pelvic calyceal system. Once entered into the pelvic calyceal system, I safely parked the guide wire and ascertained that it is in the bladder with CM image. Over the guide wire, I have placed a 5 French 26 centimeter DJ stent. You can see the guide wire passing there, and the catch point here is the stent should be placed in the upper calyx to facilitate adequate drainage. If not, there is a high chance of again closing of the mouth of the upper calyx, and then this may lead to stasis, sometimes postoperative sepsis. So this is a postoperative nephrostogram. You can see the pelvic calyceal system delineated, and it is definitely not in communication with the PCS. And also, you can see there is some extravasation on the medial aspect, but it was of no consequence. And patient has recovered well and has been discharged safely. The take home message is supine PCNL is feasible, and a upper pole access can be easily achievable in supine PCNL and can be safely performed under spinal anesthesia. Thank you very much.